Great, so I think we can go ahead and get started. Good morning, good afternoon, good evening from wherever you're joining us from. Warm welcome on behalf of the Boost team to the second session in a three-part series on JSI's Reaching Every District Using Quality Improvement Tools initiative, better known as RED-QI. Our colleagues at JSI will be leading today's session, but I want to go over a few housekeeping slides before we get started. Next slide. So for those who are joining us for the first time, the Boost community is a diverse network of more than 1,400 immunization professionals from over 125 countries. Through our online platform, boostcommunity.org, we offer opportunities for our community to connect with peers, strengthen leadership and advocacy skills, and grow in their careers. We'll be using a learning group on the platform to connect with session facilitators and fellow peers. So I do encourage you to sign up when you get a chance. We also have some orientation materials available online, but if you have any questions, you can always reach out to us at info@boostcommunity.org. Next slide. So through this series, we will examine how the RED-QI approach can help achieve equity and reduce the number of unvaccinated children through building capacity for problem solving within the system for sustainable improvements. Sessions will be taking place every Wednesday, and the final session will actually be next Wednesday. Just in case you missed one of the sessions, we'll be storing all of the session recordings and slides in the resource library of the Boost Learning Group. So be sure to bookmark this page. Next slide. So with that, I'd like to introduce the JSI team who will be facilitating today's session. So first we have Rebecca Fields. Rebecca serves as an immunization technical lead for USAID's Momentum Routine Immunization Transformation and Equity Project. With 35 years of experience in immunization, she has served in technical capacities on USAID's Global Technical Leadership Projects since 1990, as well as on programs supported by the Bill and Melinda Gates Foundation, WHO, Gavi, and UNICEF. Next, we have Pasi Mungaini, who has 30 years of experience at global, regional, national, and subnational levels in public health areas of policy, programming, health advocacy, leadership, and management. Pasi played a key role in shaping the immunization program in Uganda. He was at the helm of the immunization program in Uganda for over 10 years and led Uganda to receive a WHO award for the best EPI program in 2008. Next, we have Amare Bai, who's a senior immunization expert for JSI's Universal Immunization through Improving Family Health Services in Ethiopia project. He has a PhD in health studies and more than 15 years of experience at district, regional, and national levels in governmental health systems, academia, UN agencies, INGOs, and as a consultant. Last but not least, we have Wendy Abbey, who has over a decade of experience in empowering underserved communities and populations to access and utilize health services. Her work cuts across applying human rights and people-centered approaches to generating evidence and innovative learning for community and health system strengthening. Currently, Wendy is the technical officer at JSI for the Gavi-funded Technical Country Assistance on COVID-19 Vaccine Preparedness, Readiness, and Deployment in Ghana. Next slide, please. And before I pass it over, I just wanted to share that we are using a Zoom meeting format today, so we ask that you remain unmuted to minimize any background noise. You can always raise your hand during the Q&A portion if you want to voice over your question, or you can always use the chat box to submit your questions, make comments, and respond to other participants. So I know people have already been doing it, but feel free to introduce yourself in the chat box now. Next slide. And with that, I think I'm handing it over to Rebecca.
Great, thank you so much, Liz, and welcome to everybody. Thank you so much for joining today's session. As Liz mentioned, this is the second in a three-part series, and today we're focusing specifically on building support among those who work at local levels and can support immunization, but perhaps haven't done so in the past. We're going to describe how that can be done. Just as a quick recap from last week's session, As we discussed last week, the Reaching Every District or RED approach was developed many years ago in the early 2000s as a means of strengthening the management of routine immunization at district and sub-district levels. Over the past 10 years or so, JSI has enhanced that effort around implementing Reaching Every District by applying concepts and tools from the field of quality improvement to strengthen not so much the quality of clinical services, but rather the quality of management of immunization as a public health service intended to reach all children who are born each year, and now those later in life as well. And the purpose of introducing these tools from quality improvement is to help managers and workers at the district level, at sub-district level, and even at facility level to make RED operational, to really put it into practice. Next slide, please. And as we discussed last week, we have been introducing this RED QI approach in two countries in particular, in Ethiopia and in Uganda. In Ethiopia, this was really at quite a large scale in 103 districts across 6 regions, including in some very, very remote areas with enormous challenges. And then in Uganda as well, a different context, a different setting, working in about 25 districts in over 750 health facilities across 5 regions. Next slide, please. So we're going to be talking today about engagement of what we're calling non-health stakeholders. And just to give a little bit of background on this, why did we feel that it was important to reach out to these people who aren't normally involved in health or in immunization at local levels? Well, many countries have decentralized systems. And in those decentralized systems, there are 3 main pillars responsible for governance. One is technical, one is political, and one is the civic and administrative structure that actually administers policies. The technical refers to, for example, health, education, agriculture, and so forth. What we have increasingly recognized with immunization is that it is often the non-health stakeholders at local levels who actually control those resources that are available to districts that could be used to support routine immunization. Typically, though, in immunization, we don't take that level of governance into account and really reach out to engage them in immunization. And therefore, what we often see is that that technical pillar, the health system and the immunization program within it, often works somewhat in isolation from the civic and the political structures, as depicted here in this little graphic. So when we talk about these non-health stakeholders, who exactly are we talking about? Well, they go by different names in different countries, depending upon the structure, the governance structure in a given country. So for example, very important is the chief district civil servant or servants who have financial decision-making authority as to how resources are actually allocated at district level. We have district commissioners, we have assemblymen. These may be elected or appointed officials. We have in Uganda, there's a level called the Senior Secretary of Health. At lower than district level, we have local council chairs, as they're called in Uganda. These are elected officials. Again, they don't necessarily have a background or knowledge of health, even as they do have the welfare of their communities as their main responsibility. And of course, we have community leaders, school heads, religious leaders, those sorts of community representatives that more often we do tend to engage in immunization. Next slide, please. So as we look at RED QI and view it as a pro-equity approach, as was described last week in the webinar on RED QI, and we look at the different elements of the RED approach and how RED QI actually adds to them, we see that the non-health stakeholders actually have roles to play across the 5 different RED components. Certainly on the left-hand side here in the planning and management of resources, because these officials have a key role to play in administration and resource allocation. Certainly in reaching target populations, it's one thing to build capacity for mobile and outreach service delivery and to develop good quality plans, but what we've seen is that it's absolutely critical to have the funding that goes along with those plans so that they can actually be implemented. Engaging with communities, well, the communities represent different levels of community. We have the different types of community leaders we've already spoken about, but as well, these non-health stakeholders are part of the community as well. Supportive supervision, we use the data that comes from supportive supervision to really try to improve services. And those non-health stakeholders need to learn about that as well as certainly monitoring and using data for action. Next slide, please. So just in short, the contributions from non-health stakeholders to routine immunization play out in many different ways. And RED QI has built the capacity of the district health teams and the health teams at sub-district levels and facility levels as well to both identify who those key stakeholders are and build their capacity to engage with them in problem identification and solving, in planning, implementation, and monitoring of services, in resource mobilization to actually implement plans, and in promoting acceptance of immunization among their communities. Next slide, please. All right, so thank you very much, Dr. Pasi Mujeni, for joining us today to talk about the engagement of non-health stakeholders in Uganda. And we'd like to hear from you about a few different elements of the experience in Uganda, starting with who are the non-health stakeholders that have been engaged, and then we'll get into why engage with them. How will project goals for immunization, especially for improving equity, be achieved through their engagement? The third question will be, how has this been done? What have been the steps? And the fourth we'd like to hear from you about is what have been the achievements resulting from this non-health stakeholder engagement? Dr. Pasi, could you help us understand, to start with, who have been the non-health stakeholders that you have been engaging with in Uganda, and what sorts of roles do they play within the government structure?
Thank you, Rebecca, for giving me the opportunity to share the experience of JSI work in Uganda, and also to bring this very important topic. I've been in immunization for over 20 years, and I've realized that this topic has been like the missing link. Who are the non-health stakeholders, non-traditional health stakeholders? We are looking at the district level, and these are people who are policy implementers at the district level. For instance, the chief administrative officer and his team down in the administrative hierarchy. Then we have the political leaders at the district level, both appointed, like the resident district commissioner who represents the president, and the political leaders who are elected, like the chairman of the district council, of the council, which is the elected leader. So these are very crucial at the district level because they are the ones who allocate budget. They are the ones who also hold the opinion of the population in terms of mass education, and they are the ones who influence what goes on in the district. So these are the key people at the district level. But in Uganda, the district level has structures below, like the sub-county. The sub-county, they are also similar structures at the sub-county level, whereby you have the sub-county chief, you have the sub-county administrator, you have the sub-county elected leaders. Then when you go down below the sub-county, you also have an equivalent structure where the representation of the health workers is actually dealing with a local council one, opinion leaders, and also the people who are elected at that level and household heads. So in terms of who, the technical people at the district level, like the district health officer, links directly with the political leaders and administrative leaders. The manager of a health center at a health center 3 or health center 2 is also directly linking with the political leaders at that level, and at village level, the volunteer is also linking with household heads. So as you can see on the screen, this diagrammatic representation of what I've been talking about summarizes it all, that the technical people who have been, the key people who have been dealing with, they have to deal with the political leaders, the administrative leaders, who actually are policy makers, policy implementers, and they decide on resource allocation. If I can go on to answer the second question of, we have been looking at who are these people, and we are going to see how have they been approached. Generally speaking, these are government officials. They are local government officials. They are there doing their work. But what has been the missing link was the technical people planning on their own, developing micro plans, and they don't throw it over to the other side on the political and administrative leaders. So the first among the steps that were taken was actually to find them in their offices, introduce the idea of working with them, attend the district council meetings, attend the sub-county council meetings, and engaging them in micro-planning, in identifying the problems, and in designing the solutions. Also engaging them in the monitoring. During the monitoring of the project, the political leaders and administrative leaders were part of the monitoring teams. And during that exercise of monitoring, the problems would actually be identified. And once the problems are identified, the solutions are designed together. And what was interesting is that the non-health stakeholders would actually appreciate the reasons why immunization is not performing well, and this would actually help them to easily participate in designing solutions. Where the solution required resources, it would be easy for a district chief accounting officer, like the chief administrative officer, to say, I'm going to earmark more resources to put on outreaches. The same at the sub-county level. They would come forward and say, I'm allocating extra resources from the district generated resources to do A, B, C, D. And I think we have examples. If Rebecca, you can give the next slide. We have some examples of the districts that actually helped to identify resources and provide some of the needed inputs.
Actually,
Some
Posse,
districts
excuse me,
bought
Posse.
motorcycles. Yes, please.
Yes, I wonder if before we move on to showing those achievements, if you could speak a little bit more to a couple of things. One is, could you give us a little bit more information on how district health officers and others within the health sector at decentralized levels first came to approach those non-health stakeholders? Did they need some special orientation? Did they need some help to try to be able to explain immunization and the issues around immunization performance to those non-health stakeholders who don't necessarily know very much about immunization or health? What did they have to do? What did those district health officers and sub-district health personnel need to do to be able to approach those non-health stakeholders? So that's one question. The other question is, did this process of engaging non-health stakeholders in supporting immunization require new processes to be set up? Or was it a matter of building on existing governmental processes for planning, for review, for budgeting, and so forth? And these processes were enhanced by bringing district health personnel into the discussions?
Yeah, thank you very much for that question. I think what I need to inform the listeners and the viewers that this engagement did not involve creating parallel structures. The engagement involved people who are in the local government structures, people at the district level who are actually serving as government officials. It is within their mandate to implement and oversee, know how to do it, and they didn't know it was their role. So this engagement involved only people who are within the local government structures. And that is why it was very successful. That's why it even has a very strong component of sustainability, because the district health officers engaged with the technical people at the district level, like the chief administrative officer, as I said, the elected leaders of the district, the appointed political leaders at the district and at the sub-county. So it involved people who are already with responsibility at the district level, whose mandate it is to deliver health services, including immunization. So this was a matter of orienting them, to give them basic information, to show them that their role is very vital, and to actually show them that if they participate, at the end of the day, the results of immunization will be much better. So it was not creating new structures, it was working with existing structures. And that also helps because after the project, the people in the government, local government structures, are able to continue implementing what they started. And some of them are even allocating resources to continue some of those activities, like quarter review meetings. So that was the beauty of it, involving structures that are already in existence.
Thank you so much. And can you tell us, were the district health staff and the sub-district health staff comfortable in reaching out to these players? Did they have to learn new skills or new ways of talking about immunization? Were they comfortable in, for example, revealing if there was low performance in immunization? What do you think?
Rebecca, once again, for that question is very, very important. Yes, at the beginning of the engagement, there was tension between the technical people and the non-health stakeholders, because these people, they thought that each side was feeling the other side was their fault. I remember one incident in one district in southwestern Uganda called Mbarara, where there was a meeting between the technical people, the councillors, the district elected councillors, and the district political leaders. And during that meeting, there was a near fight, because the sub-county councillors were blaming the district leaders. The district leaders were blaming the sub-county councillors. The district leaders were blaming the technical people. The technical people are saying, you don't give us enough resources. So there was a lot of ping pong until finally, toward the end, the tension was eased, and they all realized that each person has a role to play. And they all realized that this job of improving immunization could not be done by one side without the support of the other. And they also all realized that when immunization improves and children are no longer dying of measles and other immunizable diseases, technical people will be happy, politicians will be happy, administrators will have results to deliver to the central government. So once they all realize that they have something to put in, and they all have something to benefit, because the EPA, rather the DHO, has to deliver a high DPT3 coverage. The chief administrative officer has to report to the president's manifesto team that service delivery is doing very well. The elected leaders, they also have to report back at the population that they have chased vaccine preventable diseases like measles. So everybody realized we have a role to play, and we also have something to benefit. So they finally, toward the end, they all agreed to share responsibility. As implementation started, actually the non-health stakeholders took over the program, and owned it. And actually they were the ones now pushing the technical people, informing them, these are our targets and we need this level of performance. They even went ahead to say, we are giving you extra resources on top of what you receive from central government. And because of that, we want increased outreaches, we want higher coverage, we want more communities that were formerly not reached. We want you to reach them, areas that formerly were not receiving immunization sessions. So toward the end, the non-health stakeholders, the political leaders and the administrators were actually having the last laugh because they owned the program and they started pushing the technical people to do their job.
Thank you so much, Pasi. That is really fascinating and certainly very promising. And I think we could just mention here as well that JSI prepared a detailed toolkit on how to carry out such non-health stakeholder engagement that captures some of the learning about processes that you just were describing from Umbrara. Let's move on now and talk a little bit about what kinds of results and achievements, tangible results and achievements, have come out of that work. And I think you could tell us a little bit about whether it's been the same sorts of results across the board, or whether there has been some context-specific variation depending upon what those non-health stakeholders and health personnel jointly determined were the problems and the types of solutions needed. Could you tell us about those achievements, please? And we'll advance to the next slide as well. Thank you.
Thank you, Rebecca. Once again, I would put these achievements in three categories. The first and most important achievement we observed was the enhanced ownership of the program by the district leaders. The district leaders owned the program and they were ready to push for it. They were even ready to talk about it on every forum they get an opportunity. So the ownership of the program moved from the technical people like DHO, it moved to the non-health stakeholders like the RDC, the Chief Administrative Officer, and the Secretary for Health and Chairman. So ownership was enhanced. The second broad achievement was increased resource allocation. There was diversification of resources, and this was varying from district to district. As you can see in the slide, the district of Bulambuli, which is in eastern Uganda, allocated additional structures which could be used for health as a health facility to increase the reach for immunization. Then there was districts where they made bylaws. A district like Bushenyi, they made bylaws to allocate part of the local revenue, to put it onto the primary health care grant to provide additional money for immunization. For instance, Bushenyi passed a bylaw to say that 1% of the district revenue and 5% of the sub-county revenue would be supplementing immunization funds in addition to the primary health care grant. Then there were districts like Mbarara who actually put it upon themselves to do a biannual leadership forum, in which case they are discussing with the in-charges of various facilities, and they provided money to provide motorcycles where motorcycles were not, so that they increase on outreaches. The same thing happened in the far-off district of Kanungu, where even they mobilized the community members, community circle, a local bank. This was done by the local leaders to buy a motorcycle that would be used for outreaches. So these are a few examples, but in a nutshell, there was enhanced resource allocation. The third broad result that I can attribute to this engagement was the prioritization of the program in terms of discussion in the district executive committee, in the district council, in the sub-county council, and even some districts said they put DPT3 as one of the outputs for the parish chiefs. A parish chief is the lowest civil servant, lowest administrative officer at the lowest level, which is a parish which has about 1,000 population. So the government officer there, who is an administrator, in some districts was given DPT3 as his outputs, which has to be given during appraisal. That shows how the program was now prioritized by the administrators. So those three, in my view, are the key achievements, whereby enhanced ownership, enhanced resource allocation on top of what comes from central government, and prioritization of the program.
Thank you so much, Dr. Posse. This is really very illuminating. I just want to have us move on to the third and final slide that we have from Uganda, which is quotes from a couple of officials. One is from the national level of the Uganda National Expanded Program on Immunization. And the other is from a district health officer actually talking about his experience with such non-health stakeholder engagement. And just to put those up there, right. So we don't have to read through every word on this slide, but on the left-hand side, we see that from the National Immunization Program official from UNEPI, this person says, towards the end, says this has been the missing link. And they point out that the approach did not circumvent the local government. If you circumvent the local structures, you may face resentment. The elected people want to be relevant. When the technical people run away with the services, the elected people become redundant. When local governments appreciate the implications of poor performance and their roles to address it, it empowers them to take strong decisions. And then by contrast from the district health officer, he says, little did we know that they can make a great contribution in linking technical teams with the community in their various capacities. Their participation in problem analysis and quarterly performance review yielded a lot of contributions to performance improvement. And then particularly interesting here is the observation that they appreciated their roles. They held technical staff accountable, monitored performance, and advocated for services to increase access and availability. All of this, I think, gets to the points that you were raising so very well. And I should also mention that these two quotes actually came from a study of the scalability and the sustainability of RecQI in Uganda that was carried out a year and a half after the projects in question, the USAID funded project and the Gates Foundation funded project, a year and a half after they ended. So these observations are looking at the longer term picture. Posse, before we finish, any final words? And please note that we will have opportunity to hear more from you during the question and answer period.
Yeah, thank you very much, Rebecca, for those the points which are quotations from the actors in the field. My final word is that the non-health stakeholder engagement is very key because it does not require additional resources since you are dealing with people who are already in the government, and you are also dealing with people who where immunization is their output, but they did not know how to do it. So equipping them with how to do it energizes them, empowers them, and I think it's an opportunity immunization promoters should not miss. Thank you.
Thank you. Thank you very, very much, Posse Mujeni. This has been very, very helpful. So now we're going to turn to Ethiopia, and we're going to hear from Dr. Amare Baye, who is the Senior Technical Advisor for Immunization with JSI's UIFHS project, as already described. And Amare, we'd like to hear a few things from you this morning. First, could you tell us just a little bit about who some of the non-health stakeholders are in Ethiopia? You know, some of those local actors within the local government who have been engaged to support routine immunization. And then I'd like for you to share with us a few experiences, well, experiences from a couple of districts where non-health stakeholder engagement has been carried out and the kinds of achievements that have come out of that work. So first, could you please tell us a little bit about who those non-health stakeholders are that you've been working with?
Okay, thank you very much, Rebecca. So In Ethiopian context, these non-health stakeholders include this Warada administrators. Warada means in Ethiopia is equivalent to districts. So these Warada administrators are the overall administrators, and under this administration, there are sector offices like finance office and other sectors. So these are the key non-health stakeholders, including education and other sector offices are part of this Warada civil administration council members. So these are the main actors of as non-health stakeholders that support this immunization program. And as you know, in Ethiopia, there are a number of contexts from urban, agrarian, and pastoralist. So I will share you some of one district from the pastoralist and one district from the agrarian. So for example, in Etang, which is the Gambela region, the pastoralist region, so there are a number of contexts and related problems on immunization program, which is very diverse and geographically dispersed communities with seasonal uh, displacements. So this results in frequent cancellation of immunization outreach sessions due to budget constraints. So GSI was trying to build the capacity of health managers at that district level just to develop a micro plan. This micro plan is to calculate the needed number and cost of outreach sessions. And the other, they use their own data for advocacy. So this micro plan with community mapping, with appropriate or exact estimates and sites of outreach will submit it to this Warada district administration. And this results in this civil administration agreed to fill budget gap and fund 156 outreach sessions to vaccinate children in Itang district. So this is an example in pastoral. Similarly, in agrarian region, southern region called Sodozoria district, there is also agrarian context challenges for immunization program, like immunization planning process was a top-down that without involvement of the community. So just the health workers and supervisors just do a micro plan and send to the lower level. So that was a big challenge. So the other is they use an old census data or conversion factors that not accurately estimate the targets at the ground level. So JSI was discussed and build the capacity of the health managers at district level, how to develop a bottom-up micro planning. So this bottom-up micro planning includes the engagement of the community to update the target population, community mapping, and also using different structures. There are a number of informal and formal non-health structures under the administration. So these are part of the team during bottom-up micro planning exercise. So this really improved accuracy of estimate operational costs for outreach sessions to all to reach all populations. And then during the micro plan, there is an engagement of the civil administrator representatives, like the political appointed or the finance team. They observe during the discussion, during the micro plan exercise. And then this resulted 396 additional outreach sessions conducted district-wide, including additional new sites due to this bottom-up micro plan exercise with full engagement of the community. For example, in one health center, there is a 21% increase in funding due to the internal revenue of the health center. So these are some of Ethiopian examples that GSI supporting on use of non-stakeholders at Warada and community level. Thank you very much.
Thank you so much, Amari. That was really very enlightening. And I think you brought out very, very well how the involvement of community and non-health stakeholders, both in the micro-planning process itself to identify populations and their needs, is complemented by funding and support for actually implementing those micro plans. And after all, it is the implementation of the micro plans and the ability to carry out immunization that is really so essential for improving equity in immunization. We'll have more opportunity to discuss this during the question and answer period. Thank you again. So now we're going to turn to Ghana, and we're going to hear from Wendy Abbey, our technical officer with JSI in Ghana. Ghana is not a country where we have introduced Red QI per se, but we have introduced this concept of engaging the non-health stakeholders in immunization, initially through a project on second year of life vaccination that was carried out in some urban areas in Tamale and Accra. In 2019 and 2020. And now we have the opportunity again for such work in the context of the COVID-19 pandemic and the introduction of COVID-19 vaccine. So Wendy, next slide, please. We'd love to hear from you. Just very briefly, could you tell us a little bit about the Ghana project with non-health stakeholder engagement and human-centered design for the second year of life activities? Very briefly, could you give us a bit of an overview of what that work entailed and how different types of stakeholders were engaged in that activity?
Thank you very much, Rebecca. So in 2019 to 2020, JSI undertook a human-centered design approach to improving equity and coverage of second year of life vaccination amongst some urban communities in Ghana. And the idea is to increase demand and utilization of immunization services on two levels. First, amongst a group or community of girls called female headquarters. And these are young women who often carry goods on their heads in the markets, having migrated from the northern parts of Ghana to the capital cities in Ghana. And the second was to increase uptake of second year of life immunization amongst young children in schools in urban poor communities. And so in within the year 2019 and 2020, we undertook these two interventions, working with several categories of non-health stakeholders. Based off on that, currently we have reactivated the same networks of non-health stakeholders as part of our Gavi technical assistance for COVID-19 deployment, which we started this year. And the emphasis of this project is to increase demand for COVID-19 vaccination at the district levels. And so over the period, over the period, we have managed to work with local political representatives at the district and municipal assemblies. And basically these are elected officials, men and women who have political responsibility at the district level. And the idea is for them to channel health concerns and resource allocation issues from the district level to members of parliament and other decision-making bodies at the national level. And so we've been able to engage with them as part of this intervention. Secondly, the intervention also focused on working with education officials. And basically, these are the management and supervisory teams that are responsible for improving education at the district level. And this includes the security supervisors, heads of schools, school health program coordinators. In addition to that, there are specific local association of professional groups who have been highly engaged. And this we talk about professional groups that are traditional in nature. So we have a group of market women who sell wares at traditional markets in large communities. We have public transport drivers and hairdressers associations. In addition to that, there are the community gatekeepers. These actually are non-health stakeholders who have direct responsibility to peculiar groups of people in a larger community. And so, for example, in every community, you'll find a queen mother who actually has a traditional political role in mobilizing women for community engagement. And in addition to that, there are some male heads of these female porters communities that we identified as part of our 2IL intervention. And then also, we've been able to work with religious leaders, and this includes the imams and reverend ministers, and sometimes even catechists from the Catholic organizations who were actively involved in our engagement on both 2IL intervention and currently being reactivated for the COVID-19 vaccine deployment engagements. And so, like I mentioned, the non-health stakeholders have been very supportive in terms of, first of all, identifying communities which are unreached when it comes to routine immunization, and currently in our engagement around COVID-19 vaccine deployment. And it will interest you to know that there have been those who have participated in the micro planning of activities at the district level. And you've been able to reach very peculiar groups of communities that at the national level were left out in terms of information dissemination on COVID-19 vaccination, for example, and as well as targeted services being deployed in various communities. In one of our engagement, for example, we had an assemblyman who highly recommended that the district directorate invites a person with disability to participate in the district planning meetings. And this is the first time that has ever been done. And even at the national level, where the EPI has been meeting since last year in COVID-19 and COVID-19 vaccination engagements, none of them have been at the table in most of our technical working group sessions and all that. And so we had the person with disability being invited to the micro planning session, and making sure that some critical inputs go into the micro planning session. And as a result of that, we are now seeing the EPI waking up to the realization that there's a need to engage some of these special groups in their conversations on COVID-19 vaccination. And so just recently, this past Saturday, there was a training for national resource persons who would disseminate information on COVID-19 vaccination in local languages across different media platforms. And for the first time in consultation with JSI, we had a person with disability a person from the community of persons with disability who is a sign language interpreter being invited to participate in the national training sessions. And so we are seeing results in terms of recommendations coming from representatives of these non-health stakeholders, and also their peculiar involvement in helping us address specific issues that affect peculiar communities in the current deployment process when it comes to COVID-19 vaccination. Thank you very much, Rebecca.
Yeah, thank you so much for that description, Wendy. And I think one of the things that this points out is that by engaging with these different actors, not classically involved in immunization, for routine immunization, back a couple of years ago, back in 2019 and 2020, to promote second year of life vaccination, that laid the groundwork for being able to reactivate, as you put it, reactivate these networks. And one of the other points that is very striking in what you described is how these different stakeholders, whether they're part of the local government or outside of the local government, themselves are highly networked. So they themselves are in a position to be able to tap into the broader networks that they take part in. I remember during the second year of life workshops that we conducted in 2019 with these non-health stakeholders, as well as with health officials, local health officials, and caregivers, mothers. We found that, for example, the assemblyman, the local assemblyman for a given district, himself was also serving as the chair of the school management team, and that the Queen Mother that we had participating in the workshop was part of an association of Queen Mothers. And in turn, they were able to reach out to the broader networks that they are part of. So thank you very much for that. And I think this also demonstrates how critical it is to engage these networks in the current situation we face now with COVID-19 vaccine rollout. We recognize that there's a lot of hesitancy in some places around COVID-19 vaccine, but at the same time, there are also assets to build upon. There are those who are accepting the vaccine and are in a position to speak to their own experience, to demonstrate that they themselves have accepted the vaccine, and that they themselves can serve as very powerful, trusted spokespersons that can work to encourage broader uptake of the vaccine. Thank you. We have a few minutes left here. We'd love to hear questions. I cannot see the Q&A. If we have questions that have come in through raised hands, Liz, do we have questions that have come in that way?
We haven't had anyone that has raised their hand, but feel free to raise your hand now or enter your question into the chat.
Great. And so one question that I do see in the chat, and thanks to all who have provided some sharing of their experiences. Our longtime colleague, Robert Steinglass, glad that you're on this call now. You have asked the question, why is this the missing link that is so rarely activated or engaged for routine immunization by ministries of health and international partners? And how can that be changed? And I'd really love to hear from our panelists as to what they think are the reasons why local governors, local governance structures have been involved in such a limited capacity to date. Posse, if you have a good connection, I know we had some problems with that yesterday, but if you have a good connection, could you please help answer what your views are around that question?
Yeah, thank you, Rebecca, and thank you, Robert, for raising that question. In my view, the reason has always been the traditional way of approach to technical planning, that the health professionals know it all, and they knew immunization is highly technical, and the non-health stakeholders, it was thought they had no role. But the circumstances are dictating that the non-health stakeholders are critical because they are the ones who do the budget at the district level. They also influence opinion of the masses. So when it comes to acceptability of the program, the influencers of the opinion are very, very critical. And three, I think it's very vital that we bring it to them that this is part of their job. The technical people are there to help them. So the moment they know it is their responsibility, they are not doing it for someone else, they will embrace it and actually do it because they are doing it at no additional cost because they are employed by the government.
Posse, just to add to that and to get to Robert's second part, do you think there are ways that we can kind of spread this approach more widely? And I'd actually be curious to hear from other people on the line as to whether they think there would be receptivity to this approach in the places where they work. Okay.
Hello, Rebecca.
Yes.
Yeah, this is Amara.
Thanks, Mari. Yeah.
Yeah, so yes, really this is, we can say also in Ethiopian context, it's a very missed link because the understanding of the health system and the health district health managers are taught themselves as capable and fully provide and independently provide immunization services both at health facility level and outreach and mobile services. So that is, we can say it is a wrong assumption that immunization is only part of the health system. And really that poor or weak understanding of the power and the resource control part of this local administrators. So these local administrators can do anything in their geographic area because they mobilize resources and able to control the overall issues. So this understanding missed by the health system at the district and health facility level. Maybe that's that understanding now currently aware, especially that GSI advocating this issue in Ethiopia, and especially in pastoralist areas. So the health system really acknowledges and recognizes how these non-stakeholders are very, very important in communities where there are very weak infrastructure and widely dispersed areas.
Thank you so much, Amari. And Liz Colway, you mentioned that there are a couple of questions that have come in from participants, right?
Yeah, we have a couple hands raised. I think Emmanuel had shared his question in the chat, but I don't know if you wanted to voice that over, Emmanuel.
Yeah, thank you everyone. And I'm happy that a lot of issues has been raised and the panelists have tried very much to present based on individual context and country, and a very laudable contribution. Now, my question is, initially before the red Q1 approach, there had been the RIU, which is reaching every ward, and now it's reaching every district. And sometimes you look at, it's almost the same thing that has been happening over time, just trying to see if they can change the concept and probably the way that the services are being done. So, but then you look at whether the red or RIU, yes, it has been there, and then the approaches is going down to the district level and then probably to even to the settlement base. But you find out that most, especially even the context and then the program and then the approach still stands at the same. So what is quite distinct? What is the distinct point between the RIU and then the red QR approach? Thank you very much.
Thank you, Emmanuel. Maybe I can just take a quick shot at that. Different countries use different names for the, what has broadly been called reaching every district, adapting it to their own particular context. For example, with in Uganda, moving from red to REC, reaching every community or reaching every child, after every district had in fact been reached. I think we're seeing the emergence of greater attention on equity, on really reaching every last child, as we get more and more refined with the introduction of the RED approach. Really tailoring it to different contexts has been a critical aspect of that work. So it does vary somewhat from country to country. I know that we're just about at time now. We're right on the hour now. I don't know, Liz, do we have time for any additional questions? Or do we have a hard stop now?
We might be able to fit one more in. I think Rajat had a hand raised.
Okay, and Rajat, is that a question?
No, just want to share my insights in India.
Okay, just in the next minute or so, okay?
Yeah.
Please go ahead.
Yeah, so see, I can say that in India, non-health stakeholders have played a very important role in tackling vaccine hesitancy for the polio campaigns. The people having social, economic, and political influence were identified from within the community and were called community influencers. They were having influence in the community and people listened to them. So that was being done, and they actually helped in social mobilization, dealing with vaccine hesitancy, and also created an enabling environment for the vaccinators to work. They were actually sensitized in the meetings that were done at the district and the sub-district level, and they were also appreciated and recognized during those meetings, like got some certificate or a shield from the local government officials or from senior political leaders. So they feel recognized and appreciated, so they used to support the program. And this learning from polio has been replicated in routine immunization as well. And there is a communication plan which actually includes the name of influencers and the support that is required from them. So this is just a small insight that from media that I wanted to share with all. Thank you.
Thank you so much. And I think with that, we are now at the end of our session. I want to thank the speakers, the panelists, for their excellent inputs despite some of our logistical challenges. And particularly want to thank Nicole Davis on our team for making the logistics work out, as well as Liz Colway. For next week's session on the topic of improving foundational skills to build a more resilient immunization system, it would be really great if you could come prepared to discuss what is your biggest challenge with microplanning, and have you ever heard of the fishbone tool? And if so, have you ever used it? Finally, I just can mention that we've got some resources that are included in the slide set, which we'll be sending to you. Thank you again so much for your participation and attention and active engagement today, and especially to our panelists. Thank you and have a wonderful rest of your day.
Great. Thanks, Rebecca. And just a quick reminder that we also we'll be posting the discussion questions in the learning group on the Boost platform. So we'll send everyone who participated in today's session some instructions on how to find that group and answer this question. We'll hope to see you next Wednesday. Thanks so much, everyone.
Thank you. Bye.
Bye.